Hi, my name is Omar. I am a master's student at York University's Health Science and Kinesiology Department. I am studying under the supervision of Dr. Chris Ardern. My research focuses on the associations between weight discrimination and metabolic health using the CARDIA study as my database. To give you a bit of a background, we know that the prevalence of obesity is increasing over time. Currently, about a third of the people in the States or Canada are living with obesity, and it brings upon the development of several different comorbidities, and it also leads to an elevated risk of all-cause death. The major problem is that we're not good at treating it, especially in the long term, because most people don't maintain weight losses, so most people are on this vicious cycle of yo-yo dieting and weight cycling. And part of the problem lies with very unrealistic weight goals. Most dietary programs and medications can only lead to a 10% weight loss, which is clinically significant, but people are often disappointed with it, and what they would find only acceptable is basically above what's been shown by bariatric surgery. So there is a complete disconnect amongst what's clinically healthy and what is socially acceptable. So it's not the health risks that are the issue, it's the social. And a growing problem with the rise in obesity is the bias and the stigma and the discrimination that surrounds it. It's a problem that's quite often ignored and never really talked about by those who suffer from being overweight or having obesity. And to quickly define these, weight bias refers to the negative attitudes towards others because of their weight. Weight stigma refers to the stereotype and labels we assign to such people, and weight discrimination refers to actions against the people who have obesity that can cause social exclusion and inequalities. So what the case is that 10% is the most people can lose in terms of their weight, and that is clinically significant, and that will have aesthetic and health improvements, but that is also stressful and disappointing, which means you are still going to be facing those social stigmas, but even though you're a bit healthier than before, you are still going to be facing these social issues. And on a big scale, we know that weight discrimination is the fourth most common form of discrimination overall, and for women, it's actually the third most common form of discrimination. And weight stigma and weight discrimination is very pervasive. It can happen all throughout your home life, the school life, and the workplace, in your by educators, by peers, and even by healthcare workers. The problems that we are now coming to notice are often ignored and rarely discussed by those who are overweight. And so the impact of this is that these people begin to avoid preventative healthcare services. They lose the motivation for exercise. They stop exercising. They stop controlling their diet. And essentially, people with weight discrimination have higher levels of stress and higher levels of depression. They begin to have more binge eating episodes, which leads to the development of more eating disorders, and this is more so seen in children. And people begin to try more riskier forms of weight loss. And all in all, you have this depletion of the self-regulatory resources needed for weight control. And that leads to deteriorations in metabolic health, which could increase your risk for diabetes, obesity, lead to more inflammation. You have higher levels of cortisol, activating your stress responses continuously. And so currently what is unknown is the extent to which poor metabolic health is exclusively due to body weight, or if there is an independent effect of weight discrimination. And so the aim of my research is to focus and see if weight discrimination is related to metabolic syndrome, to diabetes, and abdominal obesity. And to do that, we performed a secondary data analysis using the database created by the CARDIA study. And even though the CARDIA study focused on multiple factors that could influence the development of coronary heart disease, since they studied a lot of factors, it allowed analysis in other domains. So in year 25 of the CARDIA study, they began assessing weight discrimination, from which we derived our study sample of about 1,300 people who were overweight or who had obesity. And so our main exposure variable was weight discrimination, which was broken down into three levels of no weight discrimination, a low stress weight discrimination group, and a high stress weight discrimination group. Our three main outcomes were metabolic syndrome, that is defined by having at least 3 of these listed 5 criteria. Our second main outcome is having type 2 diabetes, and the third one is abdominal obesity. And so we looked at continuous and categorical variables and compare them across our 3 levels of exposure. And then we also performed logistic regressions for each of the main outcomes, adjusting for these following variables. To briefly summarize our results, as indicated by the red bars, we see that the proportion of females as compared to males reporting weight discrimination is found to increase with increasing levels of stress, and this is consistent with prior studies that have been done on the subject. When we look at physical activity levels, that is also consistent with the literature that physical activity significantly decreases with weight discrimination, and more so in the high stress categories. And when we look at metabolic syndrome, we note that the prevalence of metabolic syndrome is higher in those reporting weight discrimination and more so in the high stress group, which is seen on the left figure. If we look at the right figure, we see that the proportion of people who have 3 or more metabolic syndrome components increases with increasing level of weight discrimination. When we turn our focus towards diabetes, we see that a higher proportion of diabetes is associated with both high and low stress weight discrimination levels, as indicated by the strong red bars. When we look at measures of a BMI, waist circumference, and abdominal obesity, we see that, as expected, all 3 of these measures is higher among those who report weight discrimination, as seen by the red bars, and it's highest in those who report high stress weight discrimination. And when we actually break down our study sample by weight classes, we can actually see a drop in the percentage of overweight individuals as we increase in the level of obesity seen on the left figure. But when we look at the right figure, we see an increase in the percentage or the proportion of people with obesity class 2 and obesity class 3. We also performed binary logistic regressions for the outcome of metabolic syndrome, diabetes, and abdominal obesity. Generally, we look at values whose confidence intervals don't cross the reference line, and odds ratios that are greater than 1 means you have a higher odds for the measured outcome. For metabolic syndrome, we see that compared to the no discrimination group, those who experienced low stress weight discrimination had a 57% greater odds of having metabolic syndrome and 90% greater odds for metabolic syndrome among those who reported a high stress weight discrimination. And so these effects persisted after we adjusted for age, sex, and race in our second model, and only the low stress weight discrimination group remained significant when we adjusted for other sociodemographic and behavioral factors. For the outcome of diabetes, as compared to no weight discrimination, those with low stress weight discrimination had almost 2-fold greater odds of having type 2 diabetes. Finally, when we look at abdominal obesity as the outcome, we have even stronger effects for both low and high stress groups in the fully adjusted model, so that is model 3. So people with low stress discrimination had a 3.4 times greater odds for abdominal obesity, while the high stress group had an even higher odds at 4.86 times greater odds of having abdominal obesity. And so, to summarize, the present study is complementing the growing body of research on weight discrimination and health, which suggesting that weight discrimination goes beyond mental health implications and can manifest itself in elevations in cardiometabolic risk. Our study adds to the literature by focusing on abdominal obesity instead of traditionally BMI-defined obesity, as abdominal obesity considers the distribution of body fat and it's an independent risk factor for cardiometabolic disorders. Furthermore, this study complements existing work showing that internalization of weight discrimination seen in the form of stress can further amplify these risk factors. Given that weight loss is difficult to maintain and people with overweight or obesity are more likely to remain so and will more than likely to experience discrimination and stress, chronic exposure to this stress may make it difficult to cope with other life events, which can further accentuate pre-existing cardiometabolic risks. So even with the overall consistency of these findings, results from the present study suggest that weight discrimination and associated stress may exacerbate or increase the metabolic syndrome components, diabetes, and abdominal obesity, which helps to provide a further explanation for the variation in health risks and also highlights actionable targets. Some of the implications of our research are that since it's a cross-sectional study, it serves as a basis and highlights the need for further investigations through longitudinal analyses and studies. This work can help bring out the importance of weight discrimination, so it helps to develop a more basic understanding of the public health implications of this issue instead of focusing on pushing people to lose weight as treatment. And this can help to shift the focus towards weight acceptance and reduce the stigma people are faced with. And so, at the most basic level, we also help to add information on the obesity related health risks and its relationship with weight discrimination.